Hi, this is Joel again, and we're back for the AnyRidge drilling guide part 2. All right, so let's get going. A lot of the little nuances about the AnyRidge system will really make your life a lot easier, and knowing the little nuances. Like we talked about earlier, the actual length of the implant. First, let me talk about the sizes. Now, the 3.5 and 4.0 do not have the 7mm length as far as the, again, the length of the implant. Starting at your 4.5 through 8.0, we do have a 7mm length implant. But in between 4.5 and 5.5, the actual length of the 7mm implant is 6.0. Now from 3.5 through 5.5, we do have 8mm, 8.5mm and longer. But the actual length is 7.5, 9, 11.5 is 10.5, 13 is 12, 15 is 14. So again, the written length is the actual length is 1mm shorter than the written length. Okay, and that does make a difference. Again, after you've performed your osteotomies, let's say again, let's use your 10mm standard. Your 10mm implant is actually a written length of 9. That ensures you actually place your implant 1mm subcrestal, or you're able to place your implant 1mm subcrestal. You don't have to. You can leave it bone level if you so choose, but you are able to place it 1mm subcrestal. Now, this factor that I'm about to talk about here is very, very key. It says dimension of unique thread design. All right. Now, the 3.5 implant is the only one at the very top of the thread here, as you can see here, this blue line. The 3.5 is the only one that is 0.5mm bigger than the actual written length, but only on this thread right here. Now, why is that? Let's take into account the form or shape of an extraction socket. As you know, as you all know, it's sort of like a ice cream cone. It's wider at the neck, so it's sort of V's, and then it's wide at the neck here. Well, that's what that width, that extra little bit of width at the very top gives you, that ability to get really good stability in extraction sockets. So the 3.5 again is only one that's 0.5mm bigger. The 4.0 through 8.0, all of them are actually 0.4mm bigger. So now what does that mean as far as width goes? And so your 4.0 implant at the very top thread, because it's 0.4mm bigger, now you divide that by 2, which is 0.2. So the actual thread width here would actually be a 4.2. But it stays the same, and 4.0 again down the length of the implant about halfway down, and then it starts tapering down. So that's why it says outer apex here, which I'm not really going to focus on the dimensions there. I'm mainly going to focus on the crestal dimension, because that's really the most important one. So your 4.5 is really 4.9, your 5.0 is really 5.4, your 5.5 is 5.9, 6.0, 6.4, and so on. Okay, but again, you have to divide that by 2. So again, a good example is your 4.0, which is 0.4mm bigger, so it's actually 4.2 on each side. Rather, because of you have to divide that by 2, obviously. So again, that's only on your top thread, and each one of these implant designs have that. Again, that's one of the secrets to this system that does give you that extra stability into extraction sockets. Now let's go over actual protocol of D1, D2, D3, and D4 for your different bone types, and let's start with the 3.5 implant. This one is relatively simple, and I'm only going to really focus on your D1 bone, because this is your most well, D1 and D2 bone, because these two measurements are your most critical. D1 for your 3.5 implant, you want to start with your Lance or your Linderman, either one. Go with your 2.0, 2.9, 3.3, and your cortical bone drill. Okay, again, with that little extra width at the neck, you're going to get, and that's one of the reasons why you want to use your cortical bone drill as well in D1 bone, to give you a little bit of passiveness in the osteotomy, and you're not overpressuring the bone whatsoever. So, by the way, your white parentheses here means optional. So in your D2, your protocol would be Lance 2.0, 2.9, 3.3, and your cortical bone drill. Is optional. It's relative to what you find and relative to your own patient. Now, obviously, we can't predict the density of bone in the patients, so therefore, we're not going to attempt to tell you, okay, this is your protocol for this, because it all just depends, right? And it all depends on what you encounter. So that's why remember that we talked about that setting your motor at 40 Newton centimeters and placing the implant with your contra angle and having a predictable amount of torque into your bone is a really good thing to do, because that measures the amount of torque that you're placing in the bone. Now, except for extraction sockets, your 4.0 or even 4.5 implant is the largest implant diameter that you want to place in D1 bone. Because again, I could show you x-rays of the implants getting stuck. I'm not going to, simply because I don't want to focus on that. I will tell you that if you go bigger in size and you're in D1 bone, you will have the tendency to get the implant stuck. Obviously, now if you're in a molar area and you're encountering D1 bone, do you want to place a 4.5 implant? Yeah, you can, actually, because of the surface area. And I'm going to show you a case a little bit later that has a 4.5 in a molar. But if you can, try to shoot for the 5.0 or 5.5. Remember the surface area that we talked about. A 5.0 by 10 AnyRidge implant has 308 millimeter squared surface area, and a 5.5 by 10 has 388 millimeter squared surface area. So again, we're going to talk about that in a little bit more in depth in just a sec. But a 4.0 implant, again, protocol for D1 bone is Lance 2.0, 2.9, 3.3, 3.8, and cortical bone drill. Again, that whole thing. And then Lance 2.0, 2.9, 3.3, 3.8. Because remember, we talked about earlier, you almost want to drill out for your dense bone protocol. You want to almost drill out to the final diameter or width of the implant. So the implant diameter is 4.0. By the way, the circle with the line through it means diameter. 4.0 diameter. So we're going to stop at our 3.8 final drill and then use our cortical bone drill and then place the implant. So notice we're almost at the end of the final diameter. And that's what that dense bone protocol meant earlier. Okay? All right. 4.5 we kind of talked about in just a second ago, but here's your protocol for D1 bone. Lance 2.0, 2.9, 3.3, 3.8, 4.3. Notice, what did we just talk about? Almost to the final diameter of the implant and your cortical bone drill. Okay, D2 bone, again, same thing. Remember that video that we showed earlier? That was a D2 bone protocol, but we drilled it out to the 3.8 implant and then use your cortical bone drill. Again, that was optional, just like we talked about, and then place your implant. So we're going to go into now some different names or nomenclature here as far as smooth and tight, or dense and soft bone. So again, you're always going to start with your either Linderman or your Lance. 2.0 is standard, 2.9 is standard. Now with your 4.5 implant, if we were in D4 bone, could we place our implant? Absolutely. But that would be considered a D4 tight or D4 dense, because why? We're under preparing the osteotomy. So again, we have control. Now, the core of the implant, remember, is 3.3. So that would be my recommendation. Drill out to 3.3 for your 4.5 implant. And could we place the implant there? Yes, that would be considered a D3 tight or D3 dense, or a D4 smooth. Okay, so these are, you can see the different nomenclatures. Now, if you're in D2 bone, again, my recommendation would be honestly to drill it out to the 3.8 and use your cortical bone drill, just like we showed in the video. Again, you don't want to get the implant stuck. You want to try to stay conservative with this system, but at the same time, again, really talk about and really pay attention to the type of bone that you're in, and only you can judge that. So with your 3.8 drill, you can place the implant very nicely because it's almost, again, to the width. But if you're in a thinner ridge area and you don't want to drill out to 3.8, again, that's your call. It's all relative to what you're into, you run into with the patient's thickness of the ridge. So that's why my preference a lot of times is 3.3 or your 3.8 with your cortical bone drill. And here's another one with your 3.8 and your cortical bone drill. This is D2 smooth, 3.8 drill, and your cortical bone drill again. However, your cortical bone drill all the way down, because this one was halfway down. This cortical bone drill was all the way down. Because remember, there's two measurements in your cortical bone drill. There's two widths. Okay, so D1 tight, and then your 4.3. You can tell if you have to drill out to the 4.3. because remember, here's your 4.5 implant, 4.3 drill, you know you're in D1 bone. So again, that is your drilling protocol for D1 bone. So now you see the different variances that you can run into. And I really wanted to show you this slide simply because, again, it just depends is the patent answer. Nobody can predict what type of bone you're going to be into. So it's really up to you as the clinician to be able to signify and really to be able to check what type of dense bone, or the technical term of D1, D2, D3, D4. Is it deep? Is it, for instance, more cortical bone at top? Is it really cancellous underneath? What are you into? So that waterless technique of anything underneath 100 RPM and drilling right into the bone with a 2.9 implant. It's a really nice little trick to use, okay? So 5.0 implant, again, is another one that you're going to use a lot of. D1 protocol for that is Lance 2.0, 2.9, 3.3, 3.8, 4.3, and 4.8. Remember, what did we just talk about? Okay, almost to the width of the implant, and then cortical bone drill. All right, one more really detailed version of that. What did we just talk about? If you're in D1 bone, you're going to go all the way to the 5.0. Now I purposely left out a drill here. This is 4.3 in your cortical bone. Remember in your kits, we talked about all your stopper drills that you have. You actually have a 4.8 drill. Now your 4.8 by 7 millimeter stopper drill can be used also as a cortical bone drill, because remember, your medium cortical bone drill goes up to 4.4. Now your 5.0 implant up top is actually 5.2. Remember, because of that extra width up top here. And if you have dense cortical bone up top, what you can actually do is drill out to 4.8 up here with your 4.8 by 7 stopper drill, and then leave the under portion, or your half of the portion in your cancellous bone, at 4.3. So you can augment your surgical procedure as needed for you, and we do give you all the tools to be able to do that with. So that's a really, really strict point. I wanted to show you that as well. So 5.0, again, you can see the final drill is 5.4 and your cortical bone drill. So again, dense bone is what we really, really, really want to pay attention to. Your D3 and D4 bones, you can have more leisurely, or not leisurely, but you have more flexibility with your ability to come up with your different surgical protocols relative to the type of bone that you run into. Okay. All right. As we talked about earlier, 6.0 through 8.0 implants are mainly for extraction sockets. You do have drills in there to be able to perform a drilling procedure for your 6.0 and 6.5 implants. But again, your 7.0 through, your 6.0 through 8.0 implant diameters have 7, 8.5, 10, 11.5, and 13 millimeter length drills. However, remember, they're only a half millimeter shorter. 6.5, 8, 9.5, 11, 12.5. Okay? All right. 6.0, D1 bone, Lance 2.0, 2.0, 2.9, 3.3, 3.8, 4.3, 4.8. 5.4, and then 5.9, and cortical bone drill. You can do that if you so choose. But again, you really, really want to pay attention to that in D1 bone and not get these implants stuck. There is a ton of surface area with these implants. So you don't, for a molar scenario, you don't have to have a 6.0 implant or bigger. You can use, remember, a 5.0 or 5.5. 90% of what you're going to use is in between 4.0 and 5.5 diameters. But if you so choose for a molar area, especially for your bruxers, your patients with really, really bad parafunctional habits, you can definitely go with these super wide implants, absolutely. Okay, 6.5, again, 5.9, cortical bone drill. And that's really the only one we recommend to go to, because why? The last drill in the kit is 5.9, and your cortical bone drill, and your implant here is your 7.0. So 7.0, honestly, through 7.5 and 8.0 are really for extraction sockets only, large extraction sockets. So please remember, the AnyRidge system is really, really totally different, as you can see now from the different drilling guides that we've performed, really different from other implant systems. Bottom line is, you really must adapt in dealing with different bone densities. Do you have to think a little bit more with this system? Yeah. And the reason is because we're not drilling into wood. There is just not a, just push on the bone. And you really shouldn't do that, because that's where you end up burning the bone in different scenarios with your bone, because bone is, as we all know, living tissue. So here's a few x-rays and panos and PAs to look at here. This is courtesy of Dr. Darrell Berg in Marrero, Louisiana. This, I believe, was an extraction socket, if I can remember correctly. But notice, again, focus on the core. Notice the core here, all right? And look at your really unique thread engagement all the way around. Again, look at your wider healing abutment, and look at your what we call S-line prosthetics. It starts smaller because of the core and then comes up. And that smallness of the core, again, preserves cortical bone, preserves your tissue, so you not only get an increase of bone, but increase in tissue. And with that S-line prosthetic, you really get nice natural emergence profiles of your crowns. Okay, this is courtesy of Dr. Jerome Smith. Here's a big wide extraction of a molar. Where's my cursor? There it is. There's endodontically failing tooth. You can see here from the CT scan. Remove the tooth, place your implant, 3 months post-op. Really nice, big, fat healing abutment on there. Nice emergence profile. Look at the bone all the way to the top, just like it's supposed to be. Here's that case that I was telling you about, a 4.5 by 10 millimeter implant right into the interseptal bony area of a molar. Okay, another great technique that you can do. Just fill in your voids here in your sockets. Dr. Smith used fusion bone, fusion and freeze-dried bone. Put that in there. 3 months later, you can, by the way, you can see your direction indicator right into the interseptal bony area here. And here you can see a larger, I believe this is a solid abutment, or maybe an easy post abutment. Either way, they're shaped the exact same way, but bottom line is, he put a molar type restoration on this 4.5 implant. Because notice again, this is your big size tooth here. So this is your larger size abutment. And your abutments do come in 4, 5, 6, and 7 millimeter profile diameters. So you can very easily match whatever size tooth that you have. So your molars would be more so for your 7 millimeter abutments, and even sometimes your 6 millimeter abutments if it's a smaller type molar. Again, your healing abutments are your secret weapon with this system. Where's my cursor? There it is. They come in 4, 5, 6, 7, 8, and 10. So you can clearly see here there's 6 implants in the maxilla with all different size healing abutments relative to where you're working with. Smaller healing abutments in the anterior, larger healing abutments in the posterior. But again, you can see really a lot of bone to implant contact and maximum thread engagement into the bone. So you can very easily load these implants. You could easily put a soft reline denture into these with your healing abutments in there for retention. Here's another nice case. Look at that large molar here, large flared healing abutment there. Okay, Dr. Larry Lindsay, immediate extraction, immediate implant placement. Again, look at your thread engagement of your implant. Nice, nice, nice thread engagement all the way up into that socket, existing socket. Dr. Sang Kwan, there's a nice little crestal sinus bump. We really didn't even get into the sinus bump itself here, but he placed the implant right up to the sinus. And again, that's a really nice aspect of those stopper drills that we have. You can prep right up to the actual sinus itself and just go into the sinus slightly with those stopper drills in a very controlled fashion without any problems. Same thing here. That's exactly what happened. Placing that larger, obviously you can see it's a molar, so you want a larger and more surface area in that area because of the vertical bone height challenges. This is Dr. Mark Multerud, same thing, sinus bump, larger diameter implant. Dr. Darrell Berg again, splitting the buccal and lingual plates there. Look at your perfect placement there. So again, just some different examples to show with this system. And this is your final case for the AnyRidge Drilling Guide Part 2. This is compliments of Dr. George Isaguirre. This one's going to be a little bit detailed and involved because I'm going to show you a testimonial that he wrote. Immediate extraction, here you clearly see the lesion. Immediate extraction, degranulate the socket, perform your osteotomy. We talked earlier about the marking drill. Here you can clearly see the marking drill and the depth gauges, or sorry, The final marking drill serves as your depth gauge, because this mark here is, or these indentations here are 7, 8.5, 10, 11.5, 13, and 15. So not only do the drills cut phenomenally well, but they also serve as, your marking drills also serve as a depth gauge. Okay, and you can clearly see again, when you use your drill as a depth gauge, you can clearly see where your alignment is nicely in the x-ray. Again, and because of the long shank in the mouth, you can see nicely again your positioning of the drill. Now, your implant was placed. The next one of the other tools that we have in the kit that really makes your life easy is these pathfinders. This pathfinder screws into the implant itself, as you can see here, so it doesn't fall out. And now you can really check your alignment as to where your implant placement is. If you need to move it, if you need to check it, that's another benefit of this implant system. If you're malpositioned, let's say slightly, let's say you're slightly mesial here, all right? You can very easily remove this pathfinder, put your handpiece adapter back in, back the implant out, and then redirect slightly the implant because of your maximum thread engagement here. And redirect slightly the position of your implant to where it's more in between your two teeth and right where you want it to go. Okay? Another advantage to the AnyRidge drilling system because of the threads. Now here you can see the voids filled in with your bone. Dr. Isageta went to a course that we had, and I'm going to read you this because he was placing, he was a very experienced clinician. He had placed about 100 implants. So let me just read it to you. It makes all the sense in the world here. I'd already been placing and restoring Nobel replace implants for about 4 years. On the Nobel replace, I had 3 widths to use: 3.5, 4.3, and 5.0. I placed over 100 implants. I was limited in where I could place them. I averaged maybe 1 or 2 implants a month. I never did second molar implants, and the maxillary sinus was always a limiting factor for my patients. I took this hands-on live surgical course in Austin, Texas with Dr. Larry Lindsay and trainer Joel Gonzalez, thinking it would maybe help expand on my basic implant knowledge. I was wrong. This course positively changed the way I do implants and my treatment planning. And again, we're going to get into this why in just a second. This was an intense surgical course that made me think differently about replacing missing teeth. You probably could go to a more expensive course, but you would be hard-pressed to get a better experience. After 3 days, I was exhausted. Dr. Larry Lindsay and myself were a good teaching team. They were right there by your side correcting things as you worked on the patient. The overall staff at Dr. Lindsay's office was great. I felt very comfortable with Dr. Lindsay's staff and patients. Because I had already had experience placing Nobel implants, I felt like I got a tremendous improvement on my implant placement technique. In the course, I was able to place Megagen implants, about 8 in total, in several clinical situations that are commonly encountered. I was also able to experience a sinus lift, ridge expansion, and better suturing techniques. Materials and surgical instruments used in the course were superior to what I was using back home. I was so impressed with the Megagen system and motor/handpiece, I bought it, along with the Mika sinus lift kit and the ridge expansion kit. All cases we did were reviewed and discussed. Since the course, I have seen things clinically much better. I have already done 20 Megagen implants, 3 sinus lifts, and some ridge expansion. My technique has improved dramatically. I have less stress about placing implants and has become an integral part of my office. I would highly recommend this course to clinicians who want to place implants who already placed implants. So, and the website, if you want to see that his testimonial written by him, is implantknowhow.com. Okay, and you can go to national courses, click on national courses, and you can see the different testimonials there. Now, here's the point I want to focus on. Yes, he places Megagen now, and he's been able to place more implants because he has more tools in his armamentarium, and that's really the key. It says, where's my cursor? I have less stress about placing implants, and it has become an integral part of my office. And that's really, really the key, because you're able to do more things with the AnyRidge implant. You're able to actually increase your patient treatment as well as the patient results and predictability. And that's really the key right there, because you're predictably able to do these procedures and get predictable torque, predictable primary stability, and predictable results. And that's really the key. We do also have partnered with Dr. Nicholas Elian from NYU. and his website is vistara.com. I'm very excited to work with Dr. Elian. He is a prosthodontist implant surgeon, and he is one of the most absolute sincere and genuine guys I've ever met. His course coordinator is, where is it? Where's my cursor? Linda T. Barba, and her email is lbarba@vistara.com. Her cell phone number is posted here. They do have, and he is in Inglewood Cliffs, New Jersey. They do have a myriad of courses that you can attend, whether it's a 20-module implant course, a 10-module implant course, a 5-module implant course, whatever you need. Not only do they have them, but they have them quite often, and are one of the benefits of going to this course is you actually get a certificate from NYU, which is really, really a plus. And again, they do use the AnyRidge system in their courses and in their facility. Okay, so bottom line is, in a nutshell, everything we just talked about, the AnyRidge system has all these biological advancements for the newest generation of aesthetically driven implants. We talked about it as to why that is the case. If you do have any questions, you can always call me, email me, whatever the case may be. But in summary, the AnyRidge truly, truly, truly is biologically advanced. It really is prosthetically elegant. And again, I'm speaking from a prosthodontist perspective because I used to work for a prosthodontist many years, and it definitely helps you get better results prosthetically, as well as it's mechanically fixated, again, because of the type of threads that it has. So please, again, if you have any questions whatsoever, call me at any time, email me, whatever the case may be. And again, Joel G at Megagen US or imegagen.com. Thank you very much, and we'll talk to you soon. Take care.